mainstreaming NTDs in public health strategies in the East African countries, Ethiopia and Kenya. This webinar series is a joint initiative of the German Society for Tropical Medicine, Travel Medicine and Global Health and the Federation of European Societies for Tropical Medicine and International Health, as well as the Canadian Network for NTDs. My name is Miriam Müller. I'm an infectious disease physician at Charité Berlin, and I will open this webinar, which will be moderated by Ronnie Alawiye, a student and young professional ambassador at the Canadian Network for NTDs based in Calgary, Canada, and Dr. Tsion Tesfa, a dermatologist working with ALERT Gursha based in Addis Ababa, Ethiopia. They will be joined by three distinguished experts who will share their perspectives on mainstreaming NTDs in a public health strategies. Over to you, Ronnie.
Hey, thank you, Dr. Müller, and hello, everyone. My name is Ronnie Alawiye, and I'm a student and young professional ambassador with the Canadian Network for Neglected Tropical Diseases, joining you today from Calgary, Canada. It's an honor to co-moderate this session alongside Dr. Tsion, a dermatologist and founder of the ALERT Gursha initiative in Ethiopia. This webinar highlights successes mainstreaming neglected tropical diseases into public health strategies in Kenya, Ethiopia, and the broader East African region, as countries take on accelerated efforts to domestically resource their NTD elimination agendas. In August this year, Kenya declared the elimination of human African trypanosomiasis, which is a remarkable achievement that highlights the country's commitment to sustained disease control. Meanwhile, Ethiopia continues to make meaningful progress on several NTDs such as schistosomiasis, trichoma, and HAT. Now in Ethiopia, we'll explore how skin NTDs are being integrated into primary health care and how these gains are contributing to healthier and more equitable communities. In Kenya, we'll examine how NTDs are being embedded within universal health coverage frameworks, ensuring prevention and treatment remain accessible to all. Each country's approach is distinct, yet both are building local capacity and the resilience to tackle NTDs as a public health priority. Together, these stories represent the power of collaboration, innovation, and locally led action in global health. We'll now move on to our panel presentations, where Dr. Tsion will introduce our first speaker.
Thank you, Dr. Müller. Ronnie, and hello, everyone. Thank you all for taking the time to join us today. My name is Dr. Tsion Tesfa Melesse, a dermatologist at ALERT Hospital and founder of ALERT Gursha, Ethiopian NTDs Initiative. It's an honor to co-moderate the session alongside Ronnie, a young professional ambassador at Canada Network for NTD. This webinar highlights the integration of neglected tropical disease into public health strategies as a crucial step towards achieving universal health coverage. It's now my pleasure to introduce our first speaker, Mr. Michel Ofire. Mr. Ofire is the program manager for neglected tropical disease at AMREF Health Africa in Kenya. His mission is to mobilize investments toward this high-impact global health initiative that improve lives and drive sustainable change. Please join me in welcoming Mr. Michel Ofire.
Thank you very much, Tsion, and good morning, good afternoon, good evening to everyone joining us today. So I think you can move to the slides. So my presentation today is on integrating NTDs into primary healthcare systems, and primarily in Kenya. And the question that we ask ourselves, looking at the 2030 NTD roadmap, can this then help us to kind of accelerate the goal that we aim to achieve is around ending the neglect, and looking at now we are midway, and with 5 years more to go, then how can we kind of accelerate the global mission around ending the neglect for NTDs? And maybe through integration into primary healthcare. So maybe it's a question that we need to ask ourselves as we proceed to the next slide. So first things first, just to ask ourselves, to remind ourselves, what is primary health care? And this is a definition from WHO, which is around rallying the whole of society with the aim to ensure that the highest possible level of healthcare and well-being, ensure the provision of health services are equitable and able to meet the needs of the people as early as possible. And this is along the continuum of care, looking at various spheres of health care around health promotion, disease prevention and to treatment, rehabilitation, as well as palliative care. But key to this is bringing health and all these interventions closer to the people, so that within their everyday environment, be it at home, be it at work, then they're able to kind of access all these interventions easily. And primary healthcare has actually three key components based on the WHO technical series published in 2018. One is ensuring these health services are integrated and able to meet the health needs of the population throughout their lives. It's able to address broader determinants, be it social determinants, economic, or other political determinants of health. And this should be done through multi-sectoral policy and action. And finally, it's around empowering the individuals and the families, the communities that are suffering for various health conditions, including NTDs, to be able to take charge of their own health. Next slide. Just to remind us a bit, this is a publication. The source document is there, published by UNICEF, and it just clearly highlights the theory of change around how primary healthcare should be organized and what are just some of the outcomes. And we know at the end of the day, we can't achieve UHC without strengthening our primary healthcare. And so the outcome of strengthening primary healthcare is actually to strengthen UHC to ensure service coverage whenever they are needed, wherever they're needed, as well as providing financial support, as well as health equity. Next slide. So the question is, why primary healthcare now? And just a few statistics. Since 2015, health improvement in terms of health services coverage have stagnated. So globally, there's a lot of traction that was made between 2000 to around 2014. But since 2015, globally, there has been a lot of stagnation with increased out-of-pocket expenditure across the globe, with currently at least 2 billion people facing financial hardship due to health, and around 50% of them experiencing catastrophic out-of-pocket health expenditure. And again, just looking at for us to, if we continue this trajectory, then we need to scale up PHC intervention so that the out of 2 billion people that are currently facing financial hardship in low and middle income countries could kind of have access to life-saving interventions that could save up to 60 million lives and increase the average life expectancy by around 3.7 years per life. And just looking at PHC, it's known to be a fundamental pillar for any health system in any country, which again is now a key driver to attaining UHC. One is that PHC will kind of increase population coverage when it comes to health services, ensuring everyone is included, ensure that services are decentralized next to the people, so it will kind of increase service coverage, and it will allow for financial protection so that if you bring services closer and you look at the principles of UHC, which is around protecting out of pocket, rather financial protection for vulnerable communities, the poor communities, then to kind of accelerate that. And finally is the evidence of the economic return of investment. This is a case study that was published in Kenya, which shows that for every $1 spent, there's a return of around $16 in terms of addressing other conditions like stunting, non-communicable diseases, anemia, TB, malaria, and other maternal and child health illnesses. Next slide. So what policies globally do we have, and how have they been adapted in Kenya? So jogging our memory back to 1978, when the Alma-Ata Declaration was made, primary healthcare was declared to be essential, healthcare based on practical, scientifically sound, and socially acceptable methods, and technology made universally accessible to individuals and families in the community through their full participation, and at the cost that the community and the country can afford to maintain at every stage of their development. And all this is towards the journey of self-reliance and self-determination. A lot has happened between 1978, but again in 2018, there was the Astana Declaration, which now we had the shift towards universal health coverage and the SDGs when we moved from the Millennium Development Goals. And the heads of states from various countries actually committed to kind of delivering primary health care and other health services that are of high quality, safe, comprehensive, and integrated, as well as ensuring that they are accessible and affordable to everyone and everywhere. And also, UNICEF also published just a framework around, just looking at the 2030, what vision do we have for primary healthcare in the 21st century, especially in the changing world. Currently, rapid economic and environmental, technology, and demographic changes. We know Africa, for instance, bears the highest youthful population. We have technology that is rapidly changing the landscape, not just in Africa, but everywhere in the world. So how then can countries adapt to that and leverage such platforms to ensure primary health care is provided at the lowest level as much as possible? Contextually, in the NTD space, we have the 2030 NTD roadmap, which emphasizes the need for integrating NTDs, prevention, diagnosis, and treatment and care into primary healthcare systems, and this still to catalyze universal health coverage. In Kenya, we domesticated the NTD global roadmap to the 2023-2027 Kenya NTD Master Plan, which still calls for integrating NTDs with ill health systems and primarily at the primary healthcare level. Other policies still enacted by the government is around the Kenya Community Health Policy that is signed in 2023. We have the Community Health Policy, which provides, the primary healthcare network guidelines, which now then provides the various model that the country has adopted, as well as the Kenya Primary Healthcare Act. Next slide. So what are some of the health system levers that can kind of guide countries in achieving primary health care? So we have at the national level, issues around leadership and governance, and then the operational layers. So there we have issues around, the political commitments, which comes together with resource allocation and strengthening health systems at the primary healthcare from national down to the primary healthcare level. The governance and policy frameworks that I've just presented in the previous slides, how they've been domesticated, like in Kenya, and ensuring financing, which should come from the national coffers as they're doing the budgeting, how then can they allocate resources into primary healthcare to kind of strengthen. But in terms of operational layers, we have communities at the center of it, where we need to ensure quality and safety of health services. We need to ensure there is physical infrastructure and the right technologies, leveraging various digital platforms to collect data that can be used real-time for decision-making, strengthening supply chain systems and ensuring that commodities are available as and when needed, monitoring and evaluation of the various interventions, and finally, just creating the nexus between the public and the private sector, because we have private health facilities and we have the public health facilities. And at that level, we still have, private companies that do a lot of corporate social responsibility that in one or another kind of influences health. Next slide. So this is just one of the models that has been adopted in Kenya in terms of the primary healthcare. There are various other models. I think various countries have adopted various models, but with Kenya, we have the hubs and spokes model. And if you look at the apex of this model in the infograph, you have the referral facility, which is usually a level 4, that is able to provide outpatient and specialized care. And below it, we have a network of facilities, usually just outpatient and able to do very minor tests using rapid diagnostic kits and maybe symptomatic and just do outpatient management at that level. But in it, this network is coordinated by a multidisciplinary team where we have at the center of it, which is composed of various health providers, and then down lower, we go to the community and the households where all this network needs to kind of provide services. So the question is, how then can NTDs fit into this model of primary healthcare that has been adapted in Kenya? Next slide. So this diagram still shows how then in the network coordination happens. So you can see still at the middle is hub, and on the opposite left and right hand side, those are the networks of facilities, slightly lower level facilities still at the top and bottom, but horizontally, then we see the communities. And so what I was just trying to highlight is in terms of the coordination in this, we have and the governance of the primary healthcare in this system, we have a management committee, we have advisory teams, and then we have facility, committees and community health units committee that kind of meet on a day-to-day or rather regularly just to kind of discuss health interventions within the primary healthcare network for our respective PHC. And in the multidisciplinary team, you can see the composition. We have, family physicians, we have medical officers, other clinical personnel that are able to go to the communities once in a while to kind of do outreaches. Currently, they do outreaches at least twice annually, and they're able to target all diseases, including neglected tropical diseases, as well as just providing health promotion services. Next slide. So this is just a model of how then entities can still fit into the primary healthcare, where we have 2 levels of government, the national and the devolved. In some countries will be districts. We're working with the counties, and their role is primarily leadership and governance and coordination. Any partners that come in from, partner organizations like ourselves from AMREF or, research institutions, universities, they come in at this level around policy, directives, development of data capture systems, financing, supply chain, and at that level, of course, providing secondary and tertiary care for cases that cannot be handled at the primary healthcare level. Then we have on the the right-hand side, where we have the health facilities. And as you saw, at the apex of the primary healthcare, we have the level 4 facility, which then theirs is around training and standardizing SOPs that have been developed at the national level, capacity building, the peripheral healthcare workers from the peripheral facilities, as well as providing supportive supervision, just detecting cases of various diseases, including NTDs, and managing them a bit earlier. We're able to provide routine testing and treatment, reporting, as well as, various other capacity building forums like CMEs. On the left, we have the communities where, are at the bottom of the chain, and they're the ones that we actually target. They're the key client here, where at the community, we then conduct integrated outreaches. Then we're able to do routine treatment, detect and find cases a bit early. Sorry about that. Yeah. So at the community, those are the activities that happen. But all in all, you can see in the bottom of at the middle, where there is the integration of NTDs into primary healthcare, some of the activities around monitoring, learning, and evaluation. You're able to do data quality audits, service quality audits, coverage evaluation surveys for whatever interventions, as well as, just trying to refine the costs. You're able to do surveillance, you're able to do routine treatments, and any other activities. Next slide. So we operationalize this model where we're able then to ensure NTD service delivery is integrated at the PHC level, and out of a period of around 6 months, we saw increased domestic resource allocation from at least 2 counties where we did the pilot. At least for the first time, they're able to domestically finance around $84,000, which is a step in the right direction, which was used for drug procurement, for treatment during the outreaches. We saw around 600,000 people and above treated routinely through the primary healthcare system between June 2024 to this year, 2025. And also in terms of the facility level testing, we've seen now cases when they are suspected in the community during routine screening, they are able to refer to the various facilities. So around more than 9,500 stool sample tested in just 2 counties, and that is out of 47 counties in the country. And the bar graph below, we can just see in terms of coverage. So the blue is showing that when we actually decentralize services and implement at the primary healthcare level, it actually kind of improves coverage vis-a-vis when we do the usual campaign-based approach that most NTD programs in various countries are using. Next slide. Yeah, so what are some of the benefits based on the pilot that we did of integrating NTDs into primary healthcare? One thing is that it's cheaper compared to the vertical and siloed approach, beyond just ensuring that it enhances coverage and ensuring services are routinely available. We had reduced implementation costs by over 30%, where we spent around $0.14 per treatment through integration into primary healthcare, compared to the standard where if we were to treat children alone through the school-based deworming programs, we would spend around $0.73. And if we added through the campaign-based, adults, it was 0.21. So this model kind of significantly reduces costs, and in light of the current changing landscapes, then part of the things we need to ask ourselves, how do we then kind of ensure efficiency of the little resources that we have? And we compare these results with GiveWell 2022 analysis, which some of the best public health programs like vitamin A supplementation, which they spend around $2.2 per treatment, where per child, supplemented, and around $0.66 per child deworm. So essentially what we're seeing is when you go lower to the primary healthcare and ensuring that you integrate and services are routinely available, then the costs significantly come lower. It also improves efficiency. We have limited resources where if, for instance, various programs are still vertical and siloed, then, once we kind of integrate and take it down lower to the primary healthcare level, then it enables co-delivery. For instance, in the 2 counties, we're able to co-deliver both vitamin A and deworming, and it kind of helped reduce the cost significantly to 0.14 per person treated. This still also helps to optimize healthcare worker time. Healthcare workers will never be enough across various countries, and we look at various WHO recommended thresholds. We are unable to achieve that, especially developing worlds are struggling with external debt. So it kind of optimizes the healthcare worker time. So essentially what we're saying is if we integrate NTDs into PHC, then it's likely to shorten the elimination period. And maybe the question is, could it accelerate the achievement of the 2030 NTD goals? Next slide. So I added this. One of my colleagues requested to add this tagline. You can just scan the QR code maybe in a second, and then maybe we'll be happy to receive feedback from that tagline. For anyone who has questions or would like to learn more, please contact me through the email address provided. Thank you. Tsion.
Thank you very much for the presentation. It was very important, and now we'll proceed to the second presenter, and the second presenter would be Dr. Shimelis, and we work together with Dr. Shimelis at AMREF Hospital. And without further ado, it's my pleasure to introduce Dr. Shimelis. Dr. Shimelis Nigussie is a dermatologist and venereology specialist at AMREF Hospital with more than 20 years of experience. He was the former head of Department of Dermatology at AMREF Comprehensive Specialist Hospital, Ethiopia, leading referral center for dermatology and leprosy, where he continues to work. He is also the current president of Ethiopian Dermatology and Venereology Association and the vice president of African Society of Dermatology. Dr. Shimelis has co-authored more than 20 peer-reviewed publications on skin-neglected tropical disease and is dedicated to advancing care for marginalized communities and strengthening advocacy for neglected tropical disease. Please welcome Dr. Shimelis.
Thank you very much, Dr. Tsion, for your generous introduction. So I'll start with the title Integrated Management of Skin NTDs in Ethiopia. So I've been engaged in the training manual development of primary care.
Not audible. Can you increase the voice? Sorry, doctor.
So I will start with the objective of my presentation. I will focus more on key achievements and our policies that support strategic framework in the integration of skin NTDs in the General Public Health program. Next slide, please. So skin-related NTDs are one of the major causes of morbidity, stigma, and reduced quality of life. This has been, has been tested through so many operational researches. Actually, the exact true global burden of skin-related NTDs are not known. So this is one of the area of research. Epidemiological studies are very important. We have to do mapping of the real situation in different countries. And disproportionately, this affects pupils who are marginalized in the community. So it affects marginalized community. So NTDs are the disease of neglected people. So this is an issue of equity. Next slide, please. So why skin NTDs matter? Because they are the major cause of morbidity, stigma, and poor quality of life. And the global burden is underreported. And most of them, majority of them, are unable to early diagnosis and treatment. And as you look at in low-income and middle countries, people with skin NTDs experience care that's characterized by poor training of healthcare workers, limited access to diagnostic facilities and medications, and inadequate clinical supervision. That ultimately leads to misdiagnosis, delayed care, and avoidable complications. So majority of these conditions, they are really not given any attention at all. Next slide, please. So our Ministry of Health has developed a strategy framework to include agrarian communities and pastoralist communities. So we are trying to adopt this one. So our focus is mainly to decentralize the service. So the service has been decentralized to this marginalized community. And the other focus of this, our strategy, is to strengthen primary care service. So nowadays, I've been also engaged at the primary care level in our setting, is to provide all health coverage, all health services down to the grassroots level. So you'll get all the service, be it emergency, non-emergency, communicable, non-communicable disease, including NTD. So they are expected to provide all this service. So the government is working very hard, to strengthen this primary health care capacity through infrastructure, through financial support, and through technical support. So you'll see remarkable achievements after a few years. The next one is community engagement. When I say community engagement, in our real practice, they are not only involved in health promotion and community awareness. They work closely hand in hand with health work staff. So they really work in screening of NTDs and other problems. They go to each community, house to house. So if there is any suspected, any condition, disease conditions, they refer to the nearby health posts and health centers. So they are really working in the prevention and also the curative aspect. So they are beyond just health promotion and just health awareness. So we have different health segments of populations like women's associations, youth support group, religious leaders. We have also so many other like village health leaders and so on. So they are really working over the years. They have so many experience and they have been playing crucial role in the primary health care setting. Next slide, please. Next one, please. So the primary health care, actually, it plays a significant role. It accounts for nearly 90% of all Ethiopian health care services provided as the primary health care level. So NTDs are an integral part of this primary health care level. So we have health extension workers. They are part of the community members. So they are trained on NTDs. So they do screening. They go home to home and do any, if there is any suspected case, they refer to the nearby health facility. And we have also center workers. They provide care according to NTD guidelines. We have developed an NTD guideline so that this could be implemented. So that could be user-friendly. And so these health centers, they are expected, and they are also really adopting this NTD guideline. So they are doing that one, okay? Next slide, please. So now I focus on the major skin NTDs in our setting, Ethiopia. So we have high burden of disease conditions like leprosy, cutaneous leishmaniasis, scabies, lymphatic filariasis, podoconiosis, onchocerciasis, mycetoma, and others. So I will focus on the clinical aspect and the programmatic aspect of these conditions. Next slide, please. So leprosy. So leprosy was, it was a vertical program in the past. But in 1999, leprosy was declared to be eliminated. That means less than 1 case per 10,000 population in Ethiopia. Then at that time, the problem was most partners, they left out and the leprosy program was left alone. So what did the government was, they integrated this service into the public health, general health care system. By doing that, the service was sustainable and every health facilities are now expected to diagnose and treat leprosy cases. By doing that, for the last 40 years, we have done a lot of cases, and we are now developing a roadmap to eliminate leprosy by the year 2030. So it's caused by lepre and mainly targets the skin and the nerves. So leprosy is a severe stigmatizing skin condition. So usually it starts the early signs of the diseases. Skin discoloration. You can see also some infiltration over the face, nodular lesions, painless lumps over the face. As you can see, if you don't treat it, it results in severe disability. So it is one of the diseases associated with severe stigma and disability. So there is no any other leprosy, there is no any other bacteria that can result in such kind of disability, disabling condition. So leprosy is a curable disease. So by doing screening of all dermatology conditions, by integrating leprosy program in the primary health care, you can see this early signs of the disease by looking at the skin. So you can suspect the disease, and then if they get treatment, they will not develop this severe complication of because of the nerve damage. So leprosy is a very good example for other NTDs that it can be integrated easily into the public health problem, into the public health service system, so that we can achieve a lot of things. Next slide, please. So I would like to show you that for the last 20 years, in the year 2000 to 2024, if you look at the incidence is really slowly decreasing. So this shows that still we have a good leprosy control program, but we need to do more. So I want you to have, we have to really shift into, making good political commitment, financial support. If you do a lot, we can really achieve a lot in 2030. So now in our country, we have started post-exposure prophylaxis in 2025. By doing that, majority of the regions, they start this one. So those individuals who have contact with leprosy patients, they are provided with this post-exposure prophylaxis. So our target is to eliminate the disease by 2030. So we'll have zero transmission, zero disability, and zero stigma. That's expected from our community, and we have developed a roadmap for that. Next slide, please. So cutaneous leishmaniasis, one of the severe stigmatizing diseases, cutaneous leishmaniasis, very rampant in our country. This is becoming, a high public health problem in our society, and usually it's caused by Leishmania because there are more than 20 species worldwide, and the commonest cause in our setting is this species, and usually it's transmitted by the bite of an infected sandfly, which is called Phlebotomus. As you can see, usually it occurs in uncovered body sites. When there is sandfly bite, there will be an infection by this parasite, so the skin will have such kind of an ulceration or indurated erythematous plaque lesion, or over the nose, what you see is a crusted indurated plaque erythematous lesion. And also, if you do investigation, if you do a smear sample taken from the skin lesion, you will find the Amastigot formosa parasite. Next slide, please. Cell, we have 40,000 new cases every year, and we have achieved a lot of, now we have around 27 treatment centers by the year 2024. So cell outbreaks will occur in one of our Somalia region that has been controlled because of our government commitment. They procure a sodium gluconate drug, thousands of vials. Because of that, this has been controlled. Next slide, please. Onchocerciasis, river blindness. This is one of the major causes of blindness, next to trauma, so that's next to trachoma. So this is caused by Onchocerca volvulus, spread by black fly bite. The main symptoms are severe itching that is, if not treated, blindness. So we have MD program, mass drug administration, that has been implemented for the last 25 years. Because of that, we have achieved, 3 million people are no more need ivermectin, and the target is to eliminate the disease by 2030. So most of the district now is in the PTA's post-transmission surveillance. Next slide, please. Next slide, please. So lymphatic filariasis that results in lymphedema. This caused by Ushlaria bancrofti, the filarial nematode. So we have 6.5 million population at risk, and our target is to eliminate the disease by 2030 through MD, mass drug administration. So we have a very good, well-structured, organized MD system and screening. Next slide, please. Podoconesis. Podoconesis is a disease that affects individuals who are barefooted. So this usually occurs in high volcanic areas where there is a red clay soil. So this disease is associated with socio-cultural issues in one of our areas, like in the western part, people, the way they move with barefoot.
Next slide, please. So we have also scabies. Nowadays we have, scabies caused by Sarcoptes scabi. And usually it results in secondary bacterial circulation if treated, and it results in post-glomerulonephritis, and it's very endemic in the climate change. There are so many affected drought areas. Because of that, in 2024, we had 170,000 cases of scabies, and our government consulted us, and because of that, they supply, procure drugs for that, and media was administered, and the disease has been controlled. Next slide, please. Mycetoma is another one of our bigger challenge. So it's Madura foot. It's caused by fungus or filaments bacteria. Often it results from injury to the skin by torn plants, and usually the signs are swelling, discharging granules, and multiple sinus openings will be there. So what will happen if you don't treat this condition? It will happen. It will result in infection of the bone, and it might result in amputation. So commonly it occurs on the feet and the legs. So by doing prevention, by telling people to wear shoes, and having hygiene and early treatment, you can prevent amputation from this disfiguring disease. Next slide, please. So we have also a national master plan that has been designed to have this implementation guideline for skin NTDs into the public health problem that has been adopted by so many districts. Next slide, please. So there are so many awareness creations and training for primary care workers on NTDs has been done. Community screening has been done. So there are so many achievements. More than 40 participants were assessed in the southern part of our country, and more than 8 skin NTDs has been detected through this community screening. Next slide, please. So in our screening, we have detected this case, which is called NOMA, in one of our areas, Afar region, because of this integrated screening of so many major NTDs. So NOMA has been doing, through rapid assessment, we have identified this case. Next slide, please. So what are the cross-cutting challenges? Limited national coordination is there. Resource constraints because of, most of these are donor dependent. And because of that, the US fund was, has been cut. And because of that, there is a big financial constraint. Supply chain delay is very common. Shortage of entomologists. We have very few entomologists. You can count them by finger. And because of that, we cannot really achieve vector control. But we have a strategy for that one. We have an integrated vector control program at national level. And unfortunately, we have also some insecurity problem because of political issues. And the other one is persistent stigma in skin NTDs, and the huge mental health burden in affected individuals is really has to be also addressed. We usually do physical disability management, but we don't really do too much on psychosocial therapy and so on. Next slide, please. What is the way forward for elimination? We have to strengthen the PHC and also expand training for healthcare workers, and community awareness should be increased. Improve supply chain management, encourage cross-cutting, cross-border collaboration. So in East Africa, we have for lymphatic filariasis and onchocerciasis, there is an East African cross-border collaboration because the transmission zone, it goes beyond the border. So there is an attempt for that one. And the last one is we have to support research and innovations in this line. Next slide, please. I have almost finalized. Let's unite, act, and eliminate NTD. Thank you. God bless you all. Next slide, please. Yes. Thank you. Dr. Tsion, over to you.
Okay, thank you so much, Dr. Doni, for your insightful presentation. As we now come to the final part of today's session, it's my pleasure to introduce our final speaker, Mr. Tesfahun Bishaw. Mr. Bishaw is the National NTDs Coordinator at the MoH-Ethiopia. With more than 15 years of experience in Ethiopia's health sector, he has provided strategic leadership in advancing policies and programs that strengthen health systems and expand access to care for communities that have been affected by NTDs. Since 2017, he has led the National Neglected Tropical Diseases Control, Elimination, and Eradication programs. Before focusing on NTDs, Mr. Bishaw worked extensively in primary health care unit coordination and health system strengthening across rural regions, gaining deep insight into how local implementation drives national success. Whenever you are ready, Mr. Bishaw, please go ahead.
Thank you, Alawiye. Okay, so I will present on the national NTD program, just focusing how the program is constructed and being implemented, just to eliminate the skin NTDs. Next, please. So my presentation, next slide, please. So my presentation will be focused on highlighting the burden of skin NTDs in Ethiopia, and I will share some experiences of the health system just to combat NTDs and its success and challenges. And finally, I will reflect on the country's priority. Next, please. So Ethiopia is one of a big country with a high NTD burden, and in more than 13 NTDs are endemic for Ethiopia. By now, Ethiopia is at the end just implementing around 3 rounds of strategic plan for the 5 years period of implementation. And now it's a good time just to prepare the 4th round of NTD strategic plan and also the sustainability plan. This time will be a good opportunity just to include the skin agenda into this the country strategy. So in each skin entities, there are specific technical working groups that are monitoring, guiding, and just exercising the leadership of those entities. And as you can see, the Ethiopian health tier system, we have the 3 level of tier, or hierarchy of the health system. At the bottom of the this figure, you can see the primary health care. That means the primary health care units are the health center, the health posts, including the district hospital. These facilities are responsible just to screen those skin entities, diagnose and treat those entities, and also referring the severe cases of skin entity into the higher level, which means to the general hospital and the specialized hospital. Next, please. And as mentioned by Dr. Shimelis, Ethiopia has a high burden of cutaneous leishmaniasis. Previously, there were caused by Leishmania atopica only, but now there is an emerging of Leishmania atopica parasite into the country that caused more than 500 cases in 2 years. So we have around 29 health facilities, not 27. We have 29 health facilities that are diagnosing and treating those cutaneous leishmaniasis. As you can see, we have around 30 million people who are living in the highland area, or which is highly risky for the cutaneous leishmaniasis. As you can see, the red shaded one is the area where cutaneous leishmaniasis is highly reported and endemic. Next, please. So lymphatic filariasis is one of, and that cause even more than 1.5 million people are still estimated to have lymphedema or leg swelling in the country. But the country is implementing the preventive chemotherapy, and we can just shrink the prevalence and the geographic distribution of the disease. And by now, we have around 21 districts, or less than 2 million people are at risk for lymphatic filariasis. And this one will be the first just to be eliminated from Ethiopia. Next slide. And the other condition of skin NTD is podoconiosis, even though that this is not the global agenda, and it's not just included in the WHO NTDs, but Ethiopia is implementing the controlling stage of this disease by strengthening the primary health care and providing continuous healthcare training to give the lifetime legs care and hygiene and other package of lymphedema prevention and morbidity management. And in the country, we have around 345 districts that are endemic for this skin condition. Next, please. And onchocerciasis in Ethiopia is the dermal only. We don't have the eye problem, eye condition of the onchocerciasis. So in the country, we have around 292 districts that requires mass drug administration, or around 30 million people are requiring biannual mass drug administration, survey, and vector or entomology assessment. Next, please. The other skin NTDs, but are not the list. The scabies is one of, as mentioned, after the El Nino or 2017, there are several outbreaks in the country, and also there are exposing or aggravating factors like internal displacement, war, and other conditions that cause scabies are abundant in the country. And every year we treat around 200,000 cases per year, and leprosy is among one. And we are at elimination phase, even though we have still more than 2,000 cases per year. Noma and mycetoma are included in the recent one, and the Ministry of Health is working on screening and surveillance, and also the health profession capacity building. And KDL is, of course, we have public. It has public health importance, even though that the problem is not that much significant, and around 50 cases per year are reported through the Leishmaniasis control program in Ethiopia. Next, please. So, to highlight specific achievements or successes, one is the policy and the strategy. We implement the neglect tropical disease program for the last 15 years. By designing the strategic interventions like preventive chemotherapy, especially for lymphatic filariasis, onchocerciasis, and scabies, and case management intervention for cutaneous, PKDL, lymphedema, scabies, noma, and currently for mycetoma, and also the continuous health education for community is being just provided. And service provision and service exemption in the hospital and the health center are our policy just to for the benefit of the patients, because those patients are the poorest segment of the population. So we should cover the medical costs in most cases. In most area or facility, these services are exempted. And also we are integrating the case screening through the health extension workers who are responsible at the community level for all communities. And also, at least we did a round of assessment, burden assessment, survey, and also we found that there are a success on reduction of prevalence, especially for the lymphatic filariasis. And the country is now committed just to procure drugs for cutaneous leishmaniasis and scabies from the domestic resource, and a capacity building just for the health centers, just by providing the diagnostic capacity, the skill capacity for the health workers, and also integrating the skin NTD into the primary healthcare unit is now being implemented successfully. And next, please. Of course, we have a challenge, and broadly, those dermal skin, skin NTDs are not just a public health oriented problem for the academia, for the researcher. Rather, those cases are just overlooked, as these diseases are a clinical, aspect of the community. Rather, these are mainly the public health problems. So still we have a low vector control, and also a low trained dermatology for skin NTDs. Still there are low diagnostics centers, and expansion are still minimal just to cover all the endemic districts or community. And also podoconus is among overlooked by the global expertise or the global health group. Next, please. Now, the country has we recommend that to have a continuous operational and implementation research, especially these diseases are climate sensitive, and whether it is being vector-borne or also you can just imagine the community against the climate change, and there are re-emerging of the diseases. So we need operational research in this area, and we should have at least innovative diagnostic methods, and also if we can do that, artificial intelligence assisted diagnostic method. And also cutaneous leishmaniasis has no just effective drug in the country, and if we do have like a new drug to be just developed by a collaborative effort, and we should just synergize the effort of skin NTD by integrating, by collaborative work with the global community, and just to have a comprehensive skin NTD guideline, and making sure that we should just realize the skin resolution at the World Health Assembly 78. So this will be one opportunity just to give, to bring the agenda of skin NTD at the country level. Thank you for your attention. It's the end of my presentation. Thank you.
Thank you, Tesfahun, and to all the speakers for sharing your inspiring work today, as well as your experiences and your insights.